Well, I'm a pathologist and I look at biopsies of GI and also liver and the biliary tract. So usually I try to attend all the sessions that involve pathology. There are many in the program because the Congress tries to be multidisciplinary, and I think this is a main message from the UEG Week, and this is a main message of where modern medicine is heading to with team working. So I'm trying to attend the multidisciplinary symposia where I can see how we can all interact together to optimize patient management. I try to attend sessions also outside my specialty because I can follow the progress of what is happening. As pathologists, we get specimens from different specialists like gastroenterologists, hepatologists, and any other medical specialty involved with GI, surgeons, of course, with a large surgical specimen. So I try to get as much as I can so I can follow what my clinical colleagues are following, and we can discuss at the same level. Well, I think UEG tries to have a basic science, and whatever is happening and highlighted in basic sciences introduced into clinics through the Today's Science is Tomorrow Medicine. So the audience who attends those sessions, I think they get a very good sampling of what today's science can bring back into the clinics. There are very good sessions on all GI organs, including the liver, which is my specialty. And the people who attend the sessions, I think they get messages of really we can have translation from science into the clinics within a few years in some cases. I think medical students are welcome in all types of medical congresses, and they can get the most they can if they attend, because they're in the beginning of their medical career, and I think UEG gives them the variety of the different disciplines, so they can attend surgical sessions, or they can attend the pure GI or the hepatology sessions, so they get a good overview of what is happening in GI medicine right now. There are also good sessions about careers, especially for the women students. Today there was a very nice session about careers in gastroenterology, and on Wednesday as well there is a session devoted on women and general career advice, which I think is quite important because we know that more than half the medical students are women, but when they get into the training and specialty level, not all of them pick specialties that have quite a lot of active patient contact. And in GI, actually, I think the number of women, well, now is increasing, but it's not as much as the men. And this is because women, especially women in gastroenterology that want to be endoscopists, they need to have a lot of support because it is up to now, especially, that not many women are involved, and we need to increase that and also increase the number of women leaders in gastroenterology. And in order to do that, we need to start from the early days, from the medical school. If you ask women lady students in medicine how they aspire to be in their more mature life as doctors, I don't see you will have many answers that many of them would like to be head of departments or heading a scientific society. And this is because they have in the back of their minds, but they're going to have a family and how they will balance this. But there are good role models out there of women who have balanced these difficult tasks, and these are not a lot different from men. In most patients with suspected drug-induced liver disease, the clinicians choose not to do a liver biopsy, and usually the management of the patient does not involve the pathology. But in the cases that there is a liver biopsy involved, then we can give important information to the clinician, not only about the presence of a certain pattern of injury in the liver that may be related with a certain drug, but we can also, with the liver biopsy, assess if there is another disease, so we can help the differential diagnosis. And recently there are studies that have shown that the liver biopsy can offer prognostic information regarding the chronicity of the liver injury. And this, I think, is very important when we manage the patients that we suspect that they may have hepatotoxicity from a certain drug. Because when you have a suspicion for drug toxicity, usually you stop all the drugs that the patient is taking, and usually the injury then becomes less as the time passes, and following up the patient, it's enough to have the best management. And also sometimes you may need to, in very serious conditions, people do give some kind of immunosuppressive therapy, especially if there are signs that there may be an autoimmune-like drug-induced reaction. Offers a great value because you can have information, as I mentioned already, about the pattern of liver injury, which can be related to certain drugs, and then you can either exclude or include some of the drugs that the patient is taking. And most importantly, I think, it helps in the differential diagnosis. So although there are some risks with the liver biopsy, these are not as high as is usually thought. And the liver biopsy, in addition to the diagnosis and the differential diagnosis, can also offer the sample. So we have liver tissue where we can do further studies in research and then advance what we know about drug toxicity based on new molecular methods or other types of interventions that we can do using the tissue, which is very valuable. Well, I think we have gone a long way with the diagnosis and the management of bile duct tumors, and mainly when we have a tumor in the extrahepatic biliary tree and there is a stricture, then we get usually a cytological specimen. With this specimen, we can either do a simple cytological analysis, but we now know that if we do fluorescent in situ hybridization, then we can have higher sensitivity for detecting malignancy, and we can also detect malignancy earlier than imaging does. So the fluorescent in situ hybridization in the cytological material from biliary brushings, I think it's very helpful for the diagnosis of bile duct malignancies. I think in both the field of bile duct tumors and liver tumors, one of the breakthroughs will be our advances in the understanding of mixed hepatocellular cholangiocarcinomas, which they may be quite rare tumors, but they need to be managed differently than pure hepatocellular carcinomas or pure cholangiocarcinomas. Sometimes we don't know exactly the details of that yet, but it's important to realize that there are these mixed tumors, that they may originate from progenitor or stem cells in the biliary tract, both intrahepatic and also from the peribiliary glands in the extrahepatic biliary tract. And these tumors may behave differently, and it's important to know that in addition to pure hepatocellular carcinomas and to pure cholangiocarcinomas, there are mixed tumors that we need to recognize and know more about them. Well, my main liver research is on fatty liver disease in the last few years. So I'm involved in the EPOS consortium. It's elucidating pathways of steatohepatitis. It's a Horizon 2020 funded project. It's a multi-center study on non-alcoholic fatty liver disease, trying to identify biomarkers for disease prognosis and also for better treatment, because right now there is no official treatment for non-alcoholic fatty liver disease. This is the continuation of FLIP, which was the previous EU-funded project on non-alcoholic fatty liver disease. And with the EPOS, we are conducting studies based on microbiome analysis, proteomic analysis, and more in-depth molecular analysis of non-alcoholic fatty liver disease, and trying to correlate this with the histological features of the disease, the diagnosis, in order to have new biomarkers and new treatments.